Lecture D, we now are going to get into pulmonary volumes and pulmonary capacity. So these, you need to pay particular attention to the definitions of. Yes, a lot of these do sound very similar to each other, but I usually try to underline or point out what are the differences. So with your pulmonary volumes, we know that we can measure the volume of air that a person can exchange with every breath that they take. So this is used as an assessment tool for correct pulmonary function. With these volumes that are measured, you have tidal volume. So this is the amount of air that you take in that's inspired and the amount that you exhale that is expired with a normal quiet ventilation. So that's usually what air you're moving in and out of the lungs while you're sitting in one of my classes. You're bored, you're about to fall asleep. That is the tidal volume that's moving. The inspiratory reserve volume and the expiratory reserve volume, those are both the amount of air that can be forcibly inspired and forcibly expired after a normal tidal inspiration or expiration. So essentially it's opposite of each other. With this, we know that the IRV and the ERV can range from 14 to 2100 milliliters, but some of the air that remains in the lung that is called the residual volume is very much necessary to help with intrapleural pressure, also with the recoilability within the thoracic and chest wall, and it does keep the alveoli slightly inflated. So residual volume is very important. Usually a lot of patient assessment has to do with tidal volume, how much air is actually being moved with normal quiet ventilation, so no forceability. The other two pulmonary volumes are actually capacities. So you have inspiratory capacity, the total amount of air one person can inspire after tidal volume. So that total air that's taken in, inspiratory capacity. The functional residual volume is what's left in the lungs. The vital capacity is how much air is actually exchanged. They assume and hypothesize that we only use the top 3/4 or less of the exchangeable air. The old stagnant air stays in the bottom third of the lungs, so that air isn't usually exchanged, so that would not be calculated as your vital capacity. And then of course our total lung capacity is all of the volumes summed together. So you have the air that's exchangeable, that's not exchangeable, the total air amount that can be held in the lungs. So of course this can be affected with those presenters that do specific presentations to like high schools and middle schools where they try to blow up hot water bottles with that plastic. So there's quite a bit of pressure exerted to blow that water bottle up, but then if they have to train with this, because if that pressure came back into the lungs, it would override the capacity of the lungs and cause the lungs to explode. As far as ventilation, we know that air is coming in new, highly oxygenated, and then the oxygen poor air is delivered out of the alveoli. So we call this gas exchange. And by simple diffusion, the oxygen goes from the air to the alveoli, and then into the pulmonary capillaries to load onto the red blood cell. Carbon dioxide goes in the opposite direction. So there's two processes or two things that are involved with gas exchange. One is pulmonary gas exchange, so that's the exchange of the oxygen, the carbon dioxide between the alveoli and the blood, and then the tissue or systemic gas exchange between the systemic capillaries out in the tissues and the body cells themselves. As far as behavior, gases obey certain laws. So one important factor that can affect gas exchange is the pressure that it exerts on the container and the solubility of that gas in water. So both of things will drive both pulmonary and tissue gas exchange. The overall pressure that the gas is exerting on the area that's containing it, and then how soluble it is in water. So this brings us up to two laws. Dalton's law states that in this whole atmosphere, you have several different types of gases at several different quantities. So the partial pressures exist so that as a mixture, you have the sum of all of the partial pressures of the individual gases. So if most of the atmosphere is nitrogen with some oxygen in it and very little carbon dioxide, those all added together would be atmospheric pressure. But if you're only talking about the pressure of the carbon dioxide, that would be the partial pressure of the carbon dioxide gas. So these partial pressures will determine where the gas moves by free diffusion in a passive transport mechanism. The greater the pressure difference, so remember the gradients exist between pressures just like they do between ions and concentrations. So the greater the pressure difference or the pressure gradient, the more rapidly the gas will diffuse down its concentration gradient or down its pressure gradient. Henry's law is the second one. So it talks about that a gas that is dissolved or is soluble in a liquid is proportional to both its partial pressure and its solubility in that liquid. So this explains the behavior of gases when it comes in contact with water within the body. Nitrogen has a very high partial pressure. 78% of the atmosphere is nitrogen by its volume, but very little nitrogen is found in the blood plasma because it can't be soluble in water. So it doesn't go into solubility with water, not found in the blood plasma. Because what's the blood plasma's consistency? Mostly water. Oxygen has a much lower partial pressure than nitrogen does, so it becomes much more soluble in water than nitrogen. So, of course, you found oxygen just dissolved in the blood plasma. Yes, most of it is on the red blood cell, but you do have a slight amount of the oxygen dissolved in the blood plasma. Carbon dioxide of the three has the lowest partial pressure, so air is less than 1% carbon dioxide by its volume, compared to 78% of the air that is nitrogen. It's also found dissolved in the blood plasma because its solubility is 20 times that of oxygen. So carbon dioxide can dissolve much faster and much more efficiently, 20 times greater concentrated than the oxygen. So when we talk about gas exchange, or the respiration that happens, there's diffusion of gases from the alveoli into the blood. We know that gases and their movement, the pulmonary gas exchange, is driven by those pressure gradients, the pressure differences. So you have the difference between the partial pressure of the oxygen and carbon dioxide in the air of the alveoli and the partial pressure of those gases in the pulmonary capillaries. So notice when you look at the chart there that your partial pressure of oxygen is much higher in the alveolus than it is in the capillary. It's almost the same, but remember, as far as partial pressures go, at 40 millimeters of mercury in the alveoli, 45 in the capillary, it's the solubility of the carbon dioxide and the lower pressure gradient that drives the carbon dioxide off of the red blood cell and into the alveolus. So that allows for the pulmonary gas exchange. There's other factors that can affect this. So we know that the surface area of the respiratory membrane, we've talked about in classes, that emphysema tears down the wall of the alveoli, so you decrease the surface area, and that would reduce and decrease the efficiency for gas exchange because there's not a lot of alveolar sacs. There's these large open cavities that are there. So reduction of surface area would reduce the efficiency of gas exchange. The thickness of the membrane, so think about pneumonia. Inflammation within the alveolar sacs would cause a much thicker membrane and not allow the gas to diffuse as effectively as it should. So the normal membrane is very thin. The respiratory membrane consists of squamous cells, of the alveoli, flat, simple layer. They share a basement membrane with the capillary endothelium, which is simple squamous epithelium, so not very thick at all. So anything that would increase the thickness, like an inflammatory response, would diminish how efficiently the gas can be exchanged and thus increase the time that it takes for the gas to diffuse. It has a thicker area to go through. The third thing is the ventilation perfusion matching or coupling. So this is where the amount of air that actually gets into the body, that's the ventilation, and the amount of blood flow, which is the perfusion within the pulmonary capillaries in the lungs, are the phenomena that keep ventilation and perfusion very closely matched or coupled. So it doesn't matter if you're ventilating the patient if the heart's not pumping blood, so you have no perfusion of the blood into the capillaries within the pulmonary circuit. The opposite of that also is true. If there's no ventilation, the patient's not breathing, it still doesn't matter if the heart is pumping. There's no exchange of gases, so the blood that is being pumped doesn't match the ventilation. So again, nature has it set up to where they usually will very closely match each other, or we use the term coupled together. So the changes in ventilation and the changes in perfusion, the blood flow goes to the area where there's most oxygen. Changes in efficiency and perfusion leads to the changes in the amount of ventilation. So airflow is directed to areas that have the most flow. You combine this together and that allows the ventilation and perfusion to match or couple one another. With tissue gas exchange, so the internal respiration that goes on at the tissue level, or we say the systemic exchange with the systemic capillaries, the oxygen and the carbon dioxide are exchanged between the blood and the tissues. So we again know that partial pressure of oxygen, carbon dioxide in the capillaries and the tissues provide the gradients that will drive diffusion of those gases. So again, there's more oxygen in the capillary than there is in the tissue. The partial pressure of the carbon dioxide is the same like it was in the lungs, but the solubility in the water will allow it to be soluble and drive it from the tissues onto the red blood cell. So we know that cells use oxygen for aerobic respiration. The partial pressure of oxygen in the tissue is quite low. The partial pressure in the capillary is quite high. So that gradient is very steep. 100 millimeters of mercury compared to 40, it drives diffusion of oxygen into the tissue. We know that as a waste product of cellular respiration, the carbon dioxide comes off, so the partial pressure of carbon dioxide is produced in large quantities because it is the waste product, so the partial pressure becomes quite high and is relatively low in the capillaries. This pressure gradient and the carbon dioxide solubility in the water favors diffusion of the gas from the tissues and the extracellular fluid into the capillaries and onto the red blood cell. So factors that can affect this efficiency out in the tissues, the surface area that's available again. We know that the capillaries branch so much that they allow for gas exchange to be efficient. The distance for which diffusion must occur, there's less distance for diffusion, the more efficient the gas is. So most capillaries are very close with the tissues that they provide the nutrients and the gases to. The perfusion to the tissues, so the greater amount of blood supply, the more efficient the gas exchange is. We've already said that the partial pressures favor the area that are perfused. That's why, again, they're coupled. So in this section, we looked at all the different volumes and the respiratory capacities. Again, make sure you do your chapter quizzes where these are listed there. Pay attention to the differences between the definitions, but how those definitions relate. Be able to state Dalton and Henry's law. Both laws, how do they work with the explanation of gas exchange that happens because of those laws. And then finally describe oxygen and carbon dioxide as far as partial pressures go, the gradients that exist, the net gas movement that occurs both in the lungs for gas exchange and then external out in the systemic tissues. And then what were the factors that affect pulmonary gas exchange.